making this possible so that these sort of innovations which come will get publicized and possibly reach many people at many corners of the world. And I congratulate for this sort of an effort, and I hope many more to come because many innovations go unnoticed in this world. Thank you very much for this sort of an opportunity for me. Let us begin the session with Jeremy's innovation. Jeremy, you're ready with it?
Yeah. So thank you very much for the invitation. My great pleasure to be here. And let me just try to share my PowerPoint here. You should be able to see it now. So first of all, I really love this kind of session on innovations. I believe innovations are most important in pushing our community forward, and hopefully we'll be able to benefit our patients ultimately. And in this talk, I'm going to talk about computer-aided endoscopic diagnosis system for bladder cancer. And bladder cancer, it's a common malignancy. And most of the time, the first line treatment will be transurethral resection. And most patients have non-muscle invasive bladder cancer, which means that a good transurethral surgery should be curative. But unfortunately, we're still seeing a very high recurrence rate of up to 50, 60%, in particular for high-risk cases. And we really need to think, why is that the case? What are the underlying reasons for that? One of the possible reason is about the bladder cancer detection part, because sometimes the tumor may be subtle and they may be prone to a missed diagnosis. And also, when we see tumors inside the bladder, we try to finish the surgery quickly, but at the same time, we may overlook cancers which are very subtle in terms of its visibility. And so this is just one of the examples where we can try to enhance the detection. So the CROWS group has conducted a clinical trial on the use of narrowband imaging. And I just want to point out to you one of the findings for low-risk non-muscle invasive bladder cancer. They found that the one-year recurrence rate in the NBI group is much lower than the white light group. It's about 5.6% versus 27.3%. But what I want to highlight here is actually the 27.3% here, because it's actually very, very high for a genuine low-risk cancer. So it's even higher than their own intermediate risk cancer group. So there is a big argument whether these are genuinely low-risk cancers or whether simply because we missed those tumors at the very beginning. Therefore, there's really a need for a better detection. And I'm going to talk about this system here because I really think a computer-aided system or artificial intelligence or deep learning system can really help facilitate the detection in terms of speed, in terms of accuracy as well. And since this is an innovation session where we wish to share how we develop these things, so I want to talk about this in a step-by-step manner. In order to develop this system, there are several crucial steps. First, you need to have a question, you need to have a database, you need to have enough data before you can talk about training up the system. And sometimes the data being collected is quite crude. You need to normalize the data in order for the computer to interpret it correctly. And of course, for every scenario, there's a subject of interest. In this particular case will be the bladder tumor. So you need to have a manual annotation of the tumor on the images, and then you need to develop an algorithm for the deep learning part. And then once you have done all these, the later part is actually easy. Once you have enough data, you need to train it, you need to validate it, and you want to test it to see whether your system really works or not. So database collection, of course, at the end of the day, we want to have videos. But then to begin with, we start with something simpler. So we need to have a lot of images. both normal and abnormal images are needed because you need to train up the system to recognize what is normal and abnormal. And then because your images can come from different systems, and it can come from rigid cystoscope, it can come from flexible scope. So the images by themselves can look quite different. So you need to somehow do some pre-processing to normalize it in terms of its size, normalize it in terms of the area that you want to look into before you actually feed into the system. Subsequently, this is the most time-consuming part. You need to set a reference for the computer to learn. So in this particular case, then we need to mark the visible tumor one by one, or any abnormal areas one by one. So this is what we call annotation. It can be annotation on anything abnormal here. And then subsequently, you want to develop an algorithm. Of course, there are many different ways of doing it. And our way is relatively simple. We use a segmenter to segment the different regions at pixel level. But more importantly, we want the computer to identify whether they look like to be cancer or it's just a normal variant. And then these are just some preliminary results of how it would look like. So you can see on your left, the most left column is a ground truth. It's something that we've marked by ourselves. The white thing is what we've marked. The middle part is what the computer has identified as abnormal. And then the third column is the real image that we're looking into. So you can see there's a considerable overlapping of the ground truth and the prediction. So it's relatively reliable in this sense. So actually the green rectangle will be denoting the ground truth area. The blue rectangle will be what the computer has identified. So similarly on the right here, then you can see a very similar figure, ground truth prediction, as well as the real endoscopic figure. And then if you look more carefully, there's a red figure there, which is the prediction. 1.0 meaning 100%. The computer thinks this is likely to be a malignant cancer. But then there will be scenarios where they will give, for example, 85% chance, 90% chance. It really depends on how they think the images relate to the final histology. And this is something that we need to feed in the system as well. And to train up this system, we used more than 100 patients' videos, images. Altogether, we have more than 4,000 images in this training set. And then preliminary, we are able to achieve sensitivity of about 80%, specificity of about 90%, resulting in an area under curve of 90.6%. I would say this is something promising, but it's not ideal. So it's just a preliminary phase where we started, but then we still need a lot more images training in order to improve this. We have actually collected more than 10. Sensitivity is about 86, 87%. Area under curve is about 92 to 93%, but we're still finalizing data, so I didn't present it here. Next step, we need to optimize the diagnostic performance. And then we need to have a real-time transmission between the endoscopy system as well as the deep learning system. This is extremely crucial because you want the system to really tell you at that particular moment when you're doing the cystoscopy. And then we need a very friendly user interface in order to facilitate the application. And of course, you need more prospective clinical trial to really investigate its value in our clinical practice. Just to let you know some of my thoughts, I previously wrote an editorial on artificial intelligence at BJUI. I think artificial intelligence is really the way to go. It might take some time, but it's really the way to go. AlphaGo is a very good example. It basically outperforms the human in the most complicated game. And to take one step further, AlphaGo Zero actually defeated AlphaGo by 100 to 0. So you can, it's really exciting and even shocking to see what AI can really achieve. But at the same time, there are a few things that we need to overcome, including understand how it actually works, because now it's still like a black box. How it recognizes the best decision is really something that needs to be understood. And then we still need a lot of regulation standards in order to facilitate application in healthcare. Hopefully, at the end of the day, we really wish to utilize AI in a complementary rather than a competitive manner. So hopefully humans and computers can work together in order to benefit patient care at the end of the day. So I would like to end my presentation here. Thank you once again for the opportunity. And of course, I will welcome any questions. Thank you very much.
Wonderful. I think Jeremy, you put it's a bullseye. Basically, I think your last statement makes the greatest sense of all. You work together and makes it better, and you'll be able to give the better results. At present, the data, what we are able to process, the data collection is still happening and still happening and still happening, and there is no end to it. I think as the data goes on adding, the results might be changing to a certain extent, and they get tweaked over a period of time. So what looks correct today might not be correct tomorrow. By 5 years down the lane, it may change itself in its own way. I think, but well, that is a way to go about, and possibly that is how the human error can be nullified to a certain extent. What do you say, Aditya? Unmute yourself.
Am I audible?
Yep, yeah, of course.
Yeah, Jeremy, I was very intrigued by your presentation. Two quick thoughts came to mind. The first was that what is the endpoint of this kind of an AI application? It seems to be that if I am able to put in a cystoscope, get these images onto your program, and then the program gives me an output that this is high grade or this is low grade, or in the neighboring areas there is CIS, that would be the culmination of such a program where I obviate the need for a biopsy and histology. What is your perceived endpoint of this application, Jeremy?
So you're right. So ideally, it's a system that is applicable real time. That is when you are doing cystoscopy, the system really identifies an area that is abnormal, then the rectangle will appear. So it tells you that where is the possible abnormal area. So you need to focus on the area, and then you can possibly do biopsy or resection of the area. So at the end of the day, you want to enhance the bladder cancer detection. You don't want to miss anything, and hopefully reduce the recurrence rate.
Excellent, excellent. The other small question here is that the whole accuracy has already reached, you said, our sensitivity is potentially very high. What were your problem areas where you had false negative and positives?
So I think the performance, it's okay. At least at the beginning, it's a good start. But I really wish to optimize it further. At the end of the day, the biggest problem is missing a malignant tissue. So the sensitivity needs to be very, very high in order to avoid missing a tumor.
Yeah.
But at the same time, you might risk a lowering of the specificity as well, because when you detect more, then you detect something that might not be tumors. So this part is a tricky part that we're trying to work on.
Excellent. Are there any other questions on the panel?
No, I think as the data goes on adding, the variations will start happening. I don't think there is any endpoint for this on any day. The endpoint today might not be true tomorrow. And will this techno replace the surgeon's eye tomorrow? Some technician like an echocardiogram, somebody puts a cystoscopy, goes across and comes out, and the computer will tell whether you have a bladder tumor or not. What do you say, Jimmy? This is the last question, and we'll go to the next.
That is actually what I'm trying to point out at the last slide. I don't think humans and computers should be competitive. We should work in a complementary manner in order to improve the patient care. So a simple answer, no, it won't replace us. We should make it help us in our clinical.
I think that's a final point of an answer, and we go to the next before it takes time. Dr. Dalela, please. Dalela? Divaka? Yeah. Unmute yourself.
Hello.
Yeah. You're online. You can go ahead.
Good. Okay. Thank you very much for asking me to present my innovation. maybe some of you have already seen part of its presentation. So I'll just take it. Can you see my screen?
Sir,
Not yet.
Okay, I'll just
we
start
have
playing it.
video only. Yeah.
It will be the video.
Yeah, we can see it.
Yes.
Is there a sound with the video, sir? We cannot hear any sound with the video.
You can comment on the video, sir. We are not able to listen to sound.
Dalila, sir, we cannot hear the sound of the video.
Dr.
Dalila, sir,
Dalila? Dr. Dalila?
Dr. Dalila? Dalila, we are not able to hear you. Hello?
We'll have to call him.
I'll just call him.
Okay, I think we are able to hear.
Line here goes up towards the dome of the urinary bladder because the black mark, just below the black mark, there is a band here. In this stent, there's another J kind band in the memory of the stent, which deflects this coil towards the dome of the urinary bladder like this. And this coil, instead of being here in front of trigone, over the trigone, onto the bladder neck, is now placed towards the dome because of this J-like band. And when now the patient breathes in and out, even if the patient breathes in and out, it will move like this. The coil will remain towards the dome. Or some patients it will open up like this a little bit, but it still remain towards the dome. So, difference in the conventional design of stent, which is a blue stent here. This is a straight piece, and a coil here. When the straight piece moves in, this lower coil will impinge on the trigone and bladder outlet. In our design, this is going there, and because of the J, this lower coil is towards the dome of the urinary bladder. Right? It is not on the trigone. The renal end of stent remains the same. The change is only in the lower end, where the third J creates an angulation of 35 to 45 degrees. Thus, there is a renal end and a vesical end. The latter has a thick black mark for cystoscopic identification of the location of third J, which is about a centimeter below this mark. Let me first tell you how to deploy the triple J stent. In the cystoscopic technique, first load the renal end over the guide wire and advance it into the ureter. As the upper end reaches the satisfactory location in renal pelvis, withdraw the guide wire and keep your endoscopic eye on the vesical end. You must have a reasonably full bladder at this stage so that the third J is able to deflect the lower coil towards the dome. How to ensure that the third J stays below the ureteric orifice? You should advance the stent into the ureter up to this thick black mark because the third J is located about 1 centimeter below this mark. You can ask the patient to breathe in and breathe out and re-verify the proper positioning of triple J and the lower coil inside the bladder. While using anti-rad method during PCNL, etc., you need two precautions. One, take care to advance the vesical end of stent into the ureter first. And second, keep the bladder reasonably full by clamping urethral catheter to ensure that the segment of stent having third J has gone inside bladder lumen. Advance stent in a manner that about 5 centimeter of stent is
seen to be going across the pubic symphysis on fluoroscopy. Once satisfied, pull out the wire and see the lower end of stent coiling in bladder. As highlighted earlier, positioning of lower coil towards the dome is crucial for avoidance of dysuria. You have to carefully avoid an excessively long segment lying inside the bladder lumen as shown in A and an invertedly placed lower coil as shown in B. Ensure an upwardly directed lower coil at the time of stent placement. This stent maintains the position in the same way even afterwards. During the act of widening, as seen on cystoscopy, the collapsing dome of bladder pushes the lower coil towards the anterior wall and anterior recess, and subsequently, during the refilling phase, it attains its previous position. Some more advantages were realized with this stent. Spontaneous extrusion of conventional DJ stent in females is not uncommon. This happens because during act of breathing, the lower coil keeps coming close to the bladder outlet. Forceful voiding can result in extrusion of lower coil. In case of triple J stent, the location of lower coil towards the dome prevents this extrusion. Even with forceful breathing, the lower coil does not come close to bladder outlet. While removing the standard DJ stent, you must have experienced difficulty in locating the lower coil as it often gets concealed behind the bladder neck. But it is very easy to spot out the lower coil of triple J stent which remains towards the dome. When the standard DJ stents are placed bilaterally, the lower coils often get entangled. This becomes an issue when you have to either remove or replace one of the stents. In case of triple J, this does not happen. During cystoscopy, you see the lower end of both stents lying far away, and you can easily work on whichever stent you wish to. There were some minor problems with triple J stent. Firstly, you should realize that the lower end of triple J is slightly longer as compared to the standard DJ, and during deployment, the lower end may stay back within the cystoscopic sheath, and you may have to push it inside bladder lumen with the scope a couple of times. In one case, the stent down migrated, which probably happened due to faulty placement of upper end of stent. So friends, my inference is that the third J incorporated in shaft of the stent to keep lower coil of stent away from the trigone helps to minimize stent dysuria. The technique of insertion is essentially the same and is easy. A multi-institutional study will of course be required to document the actual efficacy and its benefit. Thank you very much for your patient listening.
Excellent concept, Dr. Dalala.
Thank you.
Having seen your video, and you have convincingly proved to us that the deployment, the third loop has pushed the retaining coil towards the dome. The proof of the pudding is actually in a comparison on double J versus your triple bend. Have you actually got data to tell us in my trial what was the differences and what were the outcomes? Can you share your data of your trial?
I had done a study last year on 30 patients in each group, 30 patients standard DJ stent and 30 patients with a triple J stent. And these were the patients who had undergone a ureteroscopy or a PCNL. And I usually keep the stent indwelling for about 10 days post-procedure. So in that period, we collected a telephonic data from them on day 3, day 7, day 10 about only one symptom, and that is dysuria. So because otherwise, if you ask too many questions, patients get confused. So we collected this data and we found that on day 1 and day 3, both patients were having similar problem. Both groups were having dysuria. But as you move on, day 3, day 7, day 10, the remarkable reduction in dysuria with triple J stent. I guess in the initial 1 or 2, 3 days, there must have been a problem because of the catheter they have had or the procedure they have had. So both groups had dysuria, but after 3 days, triple J stent patients had markedly less dysuria. But the study is very short. It's done only by me. And as I said, it needs to be done at a multi-institutional level by different people.
Very nice. So a couple of,
Okay, go ahead.
Dr. Malik, go ahead.
No. I just wanted to say, as he said, there is a multi-institutional study necessary. Number two, we always look at as a bladder as a semi-distended or a distended structure, but you should understand there's a significant amount of time it is semi-collapsed, in fact, with a very little amount of urine inside. At that point of time, even a centimeter beyond the ureteric orifice is still on the trigone. So our idea of loop getting onto the trigone causing irritation may not be true all the time. Even a straight length of the stent itself beyond the ureteric orifice itself can trigone, because the trigone starts where the ureteric orifice ends. It doesn't start beyond it. It starts at the ureteric orifice where it ends. So I would say, Dalila, I think the idea is very good. I would require you to have a multi-institutional study. I'll forward myself if you want. That sort of a study is necessary before we say your idea is correctly innovated and it is going to be useful.
I looked at a little bit of physiology in this and the sensitivity of trigone. The maximum amount of sensitivity in trigone is where it is at the level of bladder neck.
Yep.
Rather than what it is at the level of ureteric orifices. You know?
Even that is 1.5 centimeters,
yeah,
not more than that. That's
yeah,
exactly
true.
It's exactly 1.5 centimeters, and the extent of the stent beyond the ureteric orifice is also 1.5 centimeters. But anyway, I think a multi-institutional study will answer. We'll go to the next thing. We are beyond the time already by 5 minutes.
Okay.
The next.
Thank you very much. Thank you very much.
It's our pleasure, and there's a great innovation, Dalila. As usual, you have many innovations behind you.
Thank you. Thank you very much.
We'll go to the next one.
Have a good day.
Hello?
Yeah. Yes, sir. Dr. Lalit Shah sir is the next.
Doctor?
Dr. Lalit Shah sir is the next.
Dr. Lalit Shah, VVF, yeah.
My screen sharing is disabled. Hello.
Can you try now, sir, please?
Yeah.
Your screen is not on, Dr. Lalit.
Yes.
Yeah.
Sir, it's visible now.
Yeah, it's visible. We go and you can go ahead. I think we need to stick to 7 minutes time. We are beyond 10 minutes already.
Okay. Good morning. Good morning, everyone. Orthotopic ureteric myotoplasty, that is Shah's technique for repair of VVF involving the ureteric orifice or experience. A VVF is an abnormal communication between bladder and urethra, mostly from the obstructed labor in the past. Nowadays, most of them are postoperative due to hysterectomy commonly and other gynec surgery. Incidence of fistula after hysterectomy is 0.1 to 0.2%. Various classifications, and most important here, what we want to emphasize is when the fistula is involving the ureter, so that becomes a technically demanding. There is a need for ureteric dissection and a reimplantation. Ureteric reimplantation warrants additional operative time, morbidity, and obviously there would be small but a definite risk of urine leak and anosmotic stricture. So goal of present study was to provide a rapid, easily reproducible technique for this complex VVF repair and to avoid the need of ureteric reimplantation. That was the basic philosophy in this, of course, to cure the patient from urine leakage, just like any other VVF repair. It was a prospective multicentric study from July 12 to August 19. 48 cases were there. And VVF were repaired with the orthotopic ureteric myotoplasty technique. The inclusion criteria was one or both ureteric orifice open within 5 millimeter of fistula margin. Sterile culture was ensured as usual. Exclusion criteria was if it is more than 5 millimeter away from VVF, they were excluded. VVF after surgery for malignancy or radiotherapy, they were excluded. a usual evaluation, but here the most important part was the cystoscopy, where we see the size, number, and the distance from the fistulous margin about the ureteric orifice. These are where the various demography, the size of fistula, even up to 4 centimeter or more than 4 centimeter were also there in some of these cases. In the ureteric orifice involving into the fistula, unilateral was in 38 patients and bilateral was in 10 patients. The demography, otherwise the site of fistula was various things. And some of them were even primary and few of them were even recurrent where a previous surgical attempt was done. The cystoscopy is done to evaluate basically the bladder capacity, fistula size, number, and distance between the fistula and the ureteric orifice. All the procedure were performed transabdominal route as the usual thing. Ureteric catheterization was done. Distance between the ureteric orifice and fistula margin were assessed. Orthotopic ureteric meatotomy or meatoplasty was done. That is, incising the anterior submucosal ureteric tunnel for 1 to 1.5 centimeters from the native ureteric orifice along the direction of the ureter. So this is the picture which is showing that the feeding tube is there, and then you divide it, and so then this becomes this picture. So this provides us an additional 1 to 1.5 centimeter of bladder wall for safe, easy, and tension-free repair of VVF. And meatoplasty is performed by applying 5 tacking sutures of 40 vicryl between the ureteric and the bladder mucosal margin, which we have incised. And then further surgical procedure is as usual, nothing abnormal into that. Postoperative period as usual, follow-up protocol as usual, nothing specific into that. Postoperatively, patients were evaluated every 3 months for various things: urine leak, LUTs, infective complications, sonography, and all that. And the results were that operating time was about 95 minutes. That was the most important aspect in that. Follow-up cystogram, this were done. The cystogram finding was at the end of the 3 months, grade 1 reflux was there in 16%, 16.6%, and grade 2 reflux was in 8.3%. And after 1 year, the grade 1 reflux was in 8.3% and grade 2 reflux was in 2.1%, and 2 patients were lost to follow-up. So orthotopic ureteric meatoplasty is an easy, reproducible, and a rapid technique for repair of a complex VVF. It avoids major additional procedure with theoretically possible complications, and it maintains normal anatomy by preserving intramural ureter so that the theoretical risk of kink and stenosis is avoided. So orthotopic ureteric meatoplasty technique is easy and simple way to convert a complex VVF into a simple VVF and avoids the need for ureteric reimplantation. Thank you.
Lalit, I think that's a good technique of not doing much of a job, just pushing it towards a little more lateral, maybe a little refluxing, doesn't matter. But for that movement, avoiding a ureteric reimplantation is a great idea. I don't know. I have only one question basically. Whenever a ureteric orifice gets involved into a VVF area, the whole tissue there and the muscle there is going to be completely destroyed. So just extending by that way, will you be able to get extra muscle to suture the VVF? I think possibly in some cases it might be possible, but might not be so in every case. What is your comment on that?
No, see, I personally had been practicing this since the last maybe 15 years or so. But since in 2012, we discussed in our Chhattisgarh urology meeting, and then everybody felt that we should do this. And since then, nobody is doing any reimplant. But yes, this is true that all our surgery are abdominal one, surgery, and omental interposition. And there is no failure so far.
Okay, there are some questions here which have come up on the chat box. The first was, what is your method to assess the distance of the UO from the fistula? Is it only visual?
It's visual. It's visual.
Okay, so
it's visual when we during cystoscopy it is visual, and at the time of surgery, if required, we can measure there.
So there have been instances when
See,
we
the
thought
basic
it,
thing is that whether we are getting sufficient margin to suture the bladder or not.
correct. So there have been instances when you found it was not going to be working and you had to reimplant it.
No,
There have
not
been
a
some
single one.
instances.
No, since the idea stuck to our minds,
Right.
I have been practicing this since last 15 years, and there is not a single reimplant that I had to do.
Wonderful, Lalit. I think it's a great idea. Possibly next time we should be seeing it, how it will be possible and how good it will be there. Great idea. Thank you very much for the great. I think you would have presented it as a good video, and next time it would have been better rather than a line diagram. That would have been much better appreciated, and Lalit Shah's technique would have been more popular by this time. Otherwise,
Okay, we would try to do that next time.
Please do this, sir. Thank you.
Thanks.
We'll go to the next slide. Next one. Pankaj.
Hello, good morning to everyone. Are you able to see my screen?
Yes, Pankaj, here we are visible. Yeah, you're visible.
Good morning. I had forgotten to unmute myself. So thanks a lot for this opportunity to be in the innovator section. Good morning to everyone. Greetings from Pune. I present my novel retractor for management of hypospadias and penile urethroplasty. So this is the retractor. What happened is when Dr. Kulkarni put me on the learning curve for treatment of hypospadias, I realized that the penis needs to be stretched all the time. And it was more to my colleague to do it rather than myself. There is also an inherent ability to have an human factor for fatigue and tremor whenever the penis is held stretched for a long time. This is a very small clip which I'm showing. I'm myself holding it, and it's very difficult to keep the penis stretched. One of the traditional teachings you also have while doing a hypospadia surgery is we tie a tourniquet at the base of the penis. Some people use a tourniquet which is available in the market. Some use the vascular loop, while some use the feeding tube. This needs to be released after 45 minutes so that we don't have a vascular ischemia. And I've had 3 patients come back with stricture at that particular site. So a circumferential tourniquet is always difficult. So that is the reason I designed this prototype. It was in my mind using simple components. One is a penile clamp, which is routinely available, which we use either while doing a urethrogram or after we inject methylene blue. I took a scale from my son's school box and drilled a hole in it using a laser guide and attached an artery forceps to the top. This was the first prototype, and this is actually one of the first uses. So what we need to do is we need to stretch the penis and apply it at the penoscrotal junction. There's a stitch at the glans, which is then tied to the artery forceps. Now this artery forceps can be moved up and down depending on the length of the penis. So you can have a child's hypospadias or you can have an adult penile surgery. As a result, the penis remains straight. You can keep it on the abdomen or your assistant can just help you hold it straight. This is putting a catheter at the end of stage 1 Johansson, showing that it is non-occlusive. You don't have to release the retractor, so it doesn't mean that it has got a constructive force. This is a good hemostasis it is able to achieve. And in case the retractor is released, you can see that there is going to be some bleeding, which proves that the retractor is hemostatic in nature. We had a live conference. This is the use of the retractor for doing a ureterocutaneous fistula. In fact, what's important is we really don't require an assistance when you do simple surgeries on the penis. During one of the recent programs we had in Pune, we had Dr. P.P. Saleh who had come in, and I just showed him the retractor, and he in fact did try using it live in a hypospadia session. So these are images from that ISGU Recon conference which took place. It takes little time to adapt to the retractor. We need to downscale it when it comes to pediatric patients, but when Dr. Alan Moore saw it, he says that he wants a bigger retractor because the penis in Texas is much bigger than what the retractor would accommodate. So they are both the views. You can see he has taken an incision, but there isn't much of a bleeding. So this means the retractor is hemostatic, and after we release it, we do see some amount of bleeding. So we release the retractor before we do the surgical closure. This is retractor being used by me. This was a failed hypospadias. I dedicate this retractor to my guru, Dr. Kulkarni. So I've named it as the Joshi Kulkarni retractor. It's available with Kalelkar Surgicals. This is inserting a graft. Here you see the retractor is applied. You will only see the operator's hand, in this case my hand, but you won't see any assistant hand because both the stay sutures are doing the job of lateral retraction while the penis is kept absolutely straight. I'm making a deep glance swings, but you can see there isn't much of bleeding that is taking place there. This is the urethral closure. And this keeps the hands of my colleague or assistant very free to help us during the surgery rather than having his right hand fixed holding the penis straight. The dartos layer. And this is the end result before we do the closure. So my colleagues all over the world have used this for hypospadias, failed hypospadias. They have used it for pyronis. They like it more for pyronis because what they say is in a pyronis correction, you need the penis to be stretched and kept straight. So they have used it mainly for pyronis disease and also for failed hypospadias. This is my Joshi Kulkarni retractor and dedicated to my guru. It's versatile. Yes, it's available in the market with Kalelkar. I have not patented it. I believe patenting will increase the cost. So it's available free and anyone can try it. I'm trying to design a second prototype, which would be maybe a rectangular shape, but let's see when I'm able to do that. I thank you all for a warm and patient hearing.
Congratulations, Joshi. I think that was a good innovation. But only one thing I have a doubt, which Aditya also has pushed it on the chat box, is the pressure between the two blades is entirely dependent upon the two issues: the tensile strength of that metal, whatever you have it on the other side, and the thing is the amount of tissue between the two blades. So it's not constant because the tensile strength can be varying. You see some bulldogs are very, very crushing and some bulldogs are very, very non-traumatic. At the same time, the tissue between the bulldog also matters. So how do you rate it? How do you rate it? Because you need to standardize about a small penis to a medium-sized penis to a large penis, and possibly the pressure between the two blades should be standardized according to as bulldogs are built for a small, big, and a medium arteries. I think you need to do a little research onto that passage.
I agree completely with it. And the only jugaad I would say I found on it is if it is not compressing well, you put in a gauze piece around the penis and apply it. And if it is compressing well, you leave it. So
no, if it is over compressing, you will never be able to know that. If it is overcome, you'll never be able to know that. That's exactly what we need to have a little standardization, possibly a small pressure study on a small pelvis and a pressure meter wherein how much amount of the pressure that can be compressed on. So that will be the
I already have an idea. Kodak has a paper where you can put in, and it depends on the impression, it makes a color change. So I will
that's perfect. I think if there is and somebody said rubber band apparatus at the other end also. Yes, rubber band apparatus. I think that's a jugaad most of the time everybody does. And that's congratulations. And Joshi will go to the next paper.
Yeah. So this is about 3D printing.
Yeah, go ahead.
Yeah, so this is about 3D printing in pelvic fracture urethral injuries. So We have one of the largest experience. As we all know, we have done more than 1,300 cases. Majority of the referrals to our center are complex. And a simple urethrogram, that is an RGU-MCU, works for more than 95% of patients. But we do have complex patients which are sent for MRI. The number of patients who require pubectomy in our group is about 68%. Okay. Additional to it, we are also a fellowship center where we get fellows from all across the world, where we have to train them in performing urethroplasty as well as pubectomy. And when I mean by complexity, these are the patients we get, the patients with anterior and posterior strictures with a rectourethral fistula combined, a urethra which is connected directly to the bladder neck, an injury which can be intraprostatic, so it is at the prostatomembranous region, or you can have a urethrogram which looks as if there are two bladder necks. So severe complexity can be present when we get our patient. So whenever we refer a patient in urology for a CT scan, he comes back with about 2 or 3 plates, and we know there is a plain film and a contrast film. But whenever we send him for an MRI, we suddenly have 5 and 6 plates. It has a T1, it has a T2, T2 stach, flare. I am a radiologist myself. Before doing surgery, I did radiology for 1.5 years, quit it and joined surgery. So I have been through all these protocols. And this is the commonest image that a radiologist will give you. You really can't notice it exactly unless you study deep in the details and the patient is always looking at your face. So what is the simple point that I had learned in my radiology days is that in an MRI, urine acts as a natural contrast. So if you have water, it will light up on a T2 image. So I kept the suprapubic catheter clamped, gave the patient alpha blockers an evening prior, and injected lignocaine jelly in the urethra and tied it with a simple gauze piece. So the entire anterior urethra lights up. All we have to do is a dynamic image, which is T2 sagittal, which will take less than 5 minutes. And here is an image of a patient. On the left-hand side, you can see only a Foley's bulb. But on the right-hand side, you are able to see the bladder completely, the posterior urethra, the pubic bone, the lighted anterior urethra. Now you know what is the gap. You know the relationship of the pubic bone to the rat of the lower end of the urethra. You can see the rectum is far away. So this was a simple innovation I did as far as a protocol of MRI is concerned in pelvic fracture. I'm not saying that every patient should have it. So if you draw a horizontal line at the base of the pubic bone and you look at the posterior urethra, if it is high, we know this requires a transpubic approach. And if the urethra comes below this yellow line, which is the inferior pubic margin, you know that this patient will not require an inferior pubectomy approach. While I was presenting this in Pune, one of my teachers, Dr. Date, said, "Why are you doing MRI? Why don't you do a CT scan?" And I said, CT will have a radiation. But for the next patient, I said, let's try a CT scan. So I injected the contrast in the bladder and the same in the urethra, took 5 mm sections, and I did a 3D reconstruction for it. And then the next idea was, why don't we are able to print this 3D? So this is a patient which has got a very high bladder neck. This is how a 3D reconstruction will look. I Googled it. Trust me, even if you Google now, there are enough 3D printers available around our area. I had 20 in Kothurud. I found hold of one. This was the Ultimaker 3D printer. I just gave him the 5 mm cuts. He was very used to it. It took about 20 hours, and this is how he gave me back a nice 3D printed design of the pelvic fracture with a full bladder. You can see the posterior urethra. You can see the pubic arch. This is the inferior view. You just rotate it, and you can see that the posterior urethra is higher than the inferior pubic margin, and this patient will need a pubectomy. Similarly, a urethrogram and a 3D printing of another patient. The only flaw that I found in this technique was the anterior urethra was hanging. So you need to have a bar. So what you see, a transverse bar, is actually an attachment for the image. But in this particular patient, you can see the urethra is a U-shaped rather than a straight posterior urethra that we see. This is a short video clip of the 3D printed models that we had. So to get a better view, I've printed about 10 of them. This is only in complex cases. This, I just got it home painted, some work for my son. So you can see the posterior urethra, which is curved, the pubic bone. Here you can just rotate it. See, the posterior urethra is far away from the rectum. It is closer to the inferior pubic arch. I'm not able to print the soft tissues currently. The CD printer only takes a high contrast. So we can't print the soft tissues along with the posterior urethra. But it gives us an idea where the posterior urethra would be in a surgery. We have shown this to all our fellows and all the visitors who came, and it really helps in orientation of the posterior urethra of the rectum and the pubic bone. It does help in predicting pubectomy and the direction of displacement. So the observers and the fellows did like an idea. There was a visual score which we did, which we published in the Turkish Journal of Urology. And what I want to do now is to make this of an cancellous material rather than a polyacrylic material, so my fellows can practice pubectomy a day prior to going into surgery. So this was the advantage. In fact, this year I got an email from Aunt Mini, which is very popular in radiology, and they published this particular technique in the European part. And this is our paper, which has been accepted at the Turkish Journal, where we have also added the visual scores of all the observers and fellows. Thank you all for a warm and patient hearing.
Thank you, Joshi. It's a nice idea. Whatever information what you get in respect to whatsoever way you get, it is going to be beneficial in your planning. There is no doubt. We started with 2 bougies on either side and taking a plain X-ray on an oblique angle, and then we started looking at it in a CT scan, and now you got an MRI, and then 3D printing it and visualizing it. But only one thing which possibly may not correlate exactly is whatever lumen what you are seeing is going to be a useful urethra or not. It may give you an idea about pubectomy part is concerned, but whatever lumen you see as a urethra, is it useful for an anastomosis or not, is one thing which possibly is unpredictable and which can be seen only after exploration. What is your comment on that?
Yes, so there is artificial intelligence and human intelligence, and we can never replace the human intelligence. So that is going to be our tactile and a visual part, which is definitely necessary. So this is mainly as a teaching aid and worry for people how to do pubectomy. So this would be mainly useful for us.
I understand. I think basically majority of the cases, even the pubis doesn't look the way we are expecting it inside, and it looks in a different fashion. And what we take it as a pubis may not be only callus what you access at the end of the day. So understandably, but it gives you, as I said, whatever information what you get into your brain before you start operating is always useful at one point of time or other, in some patient or other, if not. Thank you.
It costs around 5,000 rupees. It's easily
wonderful, wonderful, wonderful. Good idea. More research ahead. Thank you, Dr. Joshi. Thank you very much for that.
Thank you, Pankaj. Very good idea. Quick question, if you may.
Yeah.
You said 3D printing is available all around. Yes. In fact, the dentists use it quite commonly.
Yes.
Only every day now for me.
Yeah.
So, will you going to specifically suggest urologists try this out outside of a teaching thing, where it's going to clinically help you? Would you consider it for all the complex cases? Where do you want to suggest urologists should ask for a 3D printed model?
I would suggest it mainly as of now for only complex cases, because it will give you an orientation. What's important is to have the bladder full and the patient void in the gantry. That's very essential. But if you see the latest publications that are coming, Dr. Prokar Das Gupta is using it for renal cancers. It's been used for prostate cancers. It's been used for everything. So definitely the orientation changes and the surgical perception. As of now, I would recommend it only for, we would recommend it only for complex cases.
Thank you. Thank you.
Let's go to the next, Aditya.
Yeah. So the next one is by Dr. Ashish Patel. This is Dr. Ashish.
Yeah.
So he's speaking on a disposable uroflowmetry. So go ahead, Ashish.
Yeah. Good morning, everybody. I'm going to discuss about a disposable uroflowmeter concept, trying to make uroflow ubiquitous. So all of us know the status of uroflowmetry today. Whenever you have to test a patient, you do a uroflowmetry, you have to do a urine macro and micro analysis, a urine culture, 3-part urine test, apart from the other tests that are required. So if you have to do a uroflowmetry, you have to find or look for a uroflowmetry setup, ask the patient for multiple voids for urine routine and uroflowmetry. Multiple samples have to be given to the pathology lab, and the patient as well as the hospital has to spend long times in collecting the samples. And the reports have to be collected from multiple places. So we started off with a concept in which I thought whether it would be possible to have one void of urine and have the uroflow as well as the other urine samples for other tests as well. So it all started with literature review and then conceptualization, designing of the concept, patenting, prototyping, and then bench evaluation of the uroflowmeter. So if we go to a short literature review, all of us know that handheld uroflowmeters are available. But the problem with these is that the calibrating holes are arranged vertically, and there is hydrostatic pressure effect on the lower holes, which gives erroneous results. It has to be performed under observation, and there is definitely a impact of the social inhibition when the patient is voiding. Multiple tests cannot be done at the same time. It is messy and leads to spillage of urine. It measures the total volume and the peak flow only, and none of them are at present available in our country. The Western literature and the patent offices also show us a couple of ideas which are electronic, but the cost being exponentially high is a problem, and these models have never picked up. What is the problem with hospital-based electronic uroflowmetry? Well, you need a dedicated space, electrical power, a technician. The technician himself is a social inhibitor who keeps on talking to the patient, asking him whether he has finished urine, started urine, etc. It is never a natural void. It is a high initial and maintenance cost. Other tests cannot be combined with the uroflowmeter, and we are dependent on MNCs for sales and support. And usually all the clinics would have an unhygienic anesthetic. So the idea came up when I was supposed to prepare for guests coming at home, and I had to fill in the ice tray for freezing. That is the time I observed that water, usually we start filling the ice cube tray from one end, and the water would usually overflow to the next one. So can we use this concept to measure uroflowmetry? And from there, the CAD designing started. And this was what the CAD figure looked like at the end. So what is the concept basically? It is a row of various cubicles which are arranged in a series. And then we have urine coming into the first cubicle, and there's a calibrated dropper there which allows urine to go fall into the lower part of the cubicle. There is a side channel as seen here, which allows a small amount of urine to go into a side chamber where we can have a strip test of urine analysis. Urine would then overflow from one upper cubicle to the next upper cubicle and so on. Urine keeps on dropping into the lower cubicles, which is through a calibrated hole. So at the end of the urine, of passing the urine, we would have fluid levels which are multiple in different chambers. And this is the data that is used for calculation of the uroflowmetry data. So the idea has already been applied for patenting, and this is the 3D print that we first got, which was made in PA12. And this is how it looks. So we have a collecting tube which allows urine to come in. Then there is a specific barcode which the model would have. There's a strip test window, and then there's a drain port. So once the patient has finished passing urine, he would just invert the can into the commode, and this would empty. And there is an aspiration port, so in case you need extra samples like culture, etc., to be collected. We went through a bench evaluation in which two types of evaluations were done, which I would come to. But the main thing that we had to do here was what I call is algorithm coding. So once you have a picture of the uroflowmeter, then how do you really figure out by calculating as to what the flows are? Bench evaluation was done with fixed flow parameters with flows of 4, 8, 12, etc. flowing into the uroflowmeter. And the same was compared with the electronic uroflowmeter just to see whether we are getting the accurate readings. Also, a graph was plotted using the disposable uroflowmeter. A variable flow was it was tested using a variable flow in which we had a latex balloon filled with various quantities of water. The same balloon was used for the electronic flow meter as well as the model that we had made. And then we try to derive a variable flow graph. So after this, the problem was that if the patient has to do the test at home, then what else do we need? Then we need a system like telereporting, and then we need to have a system for mass production and a distribution chain. So the telereporting system that now has been figured out is that the patient performs the test at home. He uploads a picture, a front picture and the side picture onto a web-based app, which is already there. And then the photos come to the headquarters, and then we would be able to deliver the report on his telephone or to the doctor, and thus the report would reach the patient. So this is the form which is available online already. And this is what the finished product looks like. So it has already been put into production, and we have received the first 10 pieces. So the patient would have a funnel like this in which he would void. So this is the funnel, and the urine would flow into the box. Then he has to send us the pictures of the front and the side here. Because of the lockdown, actually the production was stalled, and then the whole project has been pushed till the lockdown opens up again. There are do-it-yourself instructions of how the patient would use the uroflowmeter. Also, FDA guidelines of how we're supposed to dispose the uroflowmeter. It is the mass production. It is made up of polystyrene, which is well appreciated medical grade material, and injection molding is being used. So this is the box design that we have done, and the box production is also stalled because of the lockdown. So we are waiting for the same. Cost analysis has turned out to be quite a cheap one. So we are planning to make it available to a patient, maybe around 700 to 1,000, depending on where the patient is and what kind of practice the doctor is also following. So in conclusion, yes, there is a patient trial which is remaining, and that is because we do not have enough pieces at the moment. We are waiting for the lockdown. But a single-use pre-sterilized kit would be available for the patient, which would be affordable. It would be disposable. It can be used anytime. So the patient can buy it from the hospital or buy it from the pharmacy, take it home, do the uroflowmetry at his own time, and then send us the pictures. It would allow for home-based natural void uroflowmetry. So there would be no technician ready to click the mouse when the patient starts voiding. So there's no social inhibition there. It would definitely save the hospital space, time, manpower, capital, and maintenance cost for the hospital is what I feel. It would save the investigation time because the patient will not spend time in the hospital trying to do the uroflowmeter or the urine analysis and then try to wait for the report. In a single void, we would be able to do uroflowmetry, a strip analysis for urine routine. We would be able to collect urine for various other investigations if required. The parameters that it would be able to measure is the voided volume, total voided volume, the peak flow, that is the Qmax, the average flow, and the flow graph. All this we would be able to provide counting the volumes in each of the cubicles. So these are horizontally placed calibrators, and hence it negates the effect of hydrostatic pressure, which I was discussing in the first couple of slides when we go to talk about handheld uroflowmeters. There is no dependence on MNC, so this definitely is an advantage. It would be good for bedridden and chair-bound patients at home and in the hospital, and definitely can be used as a first-line screening test for remote patients in underdeveloped and inaccessible areas. Also for long-term self-monitoring, as well as if, for example, we just want to do a uroflowmetry and have a tele-consulting sort of a thing for our patients, we can ask him to buy the uroflowmeter and then send us the report. We are not using electricity here, so it's definitely a go green concept. So I think with these multiple advantages, once the lockdown is down, we would be able to start the actual patient trials. Thank you for the patient listening.
Ashish, I think you should not be talking about MNC. Yourself is an MNC. So it doesn't arise. I think globalization is so much now. I think you yourself can be considered MNCs. It doesn't matter. If the concept is good, if it is going to be affordable, and if it is going to give you that natural voiding effect, which is not going to be there in the hospital, I think that's the best thing that can happen. The only negative, this thing is a processing again, which should happen based on a picture. How far it will be feasible? If you can tumble over that block, if there is something which can be done to tumble over that block, that will be most useful, because there is an interface which is coming in again. There is one interface which comes in for analysis of the result. Yes. So that is going to be a central point again, which may be the tumbling block in your whole design.
Yeah, but at the moment we have already spoken to a couple of softwares, and there are photo recognition softwares already available, which they say can be modified and an app can be used. But at the last end, we will have to keep a human person there who actually sees whether the software is doing the right thing or not.
Yep, true.
Yeah, Ashish, what has come up from the chat box? Purely commercial question. Normal Uroflow is at the 500 to 800 rupee range. Your cost is going to be beyond this. How are the patients going to be accepting that additional thing? What do you feel? Are you going to get a price point down?
We are trying to figure out the cost at the moment. Our production cost is below 500, but then the distribution cost would also come in.
Correct.
But I think all in all, even if we are also trying to figure out that if he's not able to do it in the first word, do we give him a free second session or a free second sample? So all these logistics we are looking into, but at the end of the day, I think we would be able to give a logical, financially viable solution for the society in general. Yes.
Great idea. Thank you.
All the best. All the best. I think you should be able to do that, and I know very well sure you'll be able to make that interface also nullified to a certain extent, and it cost effective also.
Thank you.
All the best. All the best to you, Ashish.
Thank you so much.
We'll go to the next, Aditya.
Yeah. So Dr. Chandamohan is ready?
Yes, sir. Thank you,
please go ahead.
Mallikarjun sir and Aditya sir, for giving this opportunity, and Alto also. Is my screen and audio is okay, sir?
Yes. Please go ahead.
Audio is okay.
Just go full screen.
Go to slideshow mode, sir, please.
Yeah, okay. Just 1 second. So fluoro 0 RIRS. Normally we use in RIRS fluoroscopy less than PCNL.
So we can't see the slideshows.
Hello?
We can't see the slideshow.
Your slideshow.
Please go to slideshow mode of your presentation, sir.
Slides you are not able to see?
There is
the
a
slides, go to slideshow.
Yeah. Just click on the slideshow.
No, I have clicked. I am able to see complete full screen.
Just close and again select, sir.
Yeah. I am stop sharing.
Yeah.
I will start sharing again. Optimized. And you are able to see now?
Yeah.
Now I will go to the full screen. You are able to see or not?
Yes, sir.
Yes.
Yeah, please. During the PCNL, we do a lot of fluoroscopy, but whereas in RIRS, only few times we use that. That also can be zeroed. Like when we go to private practice URSL, majority of these small hospitals may not have CM, even though it is not warranted. Lower ureteric stones, we do without CM and put the stent and come out. Similarly, here, CM is mainly used for the access sheath insertion, where you pass the guide wire over the access sheath. And second part where CM is used initially to RGP and identify the calyceal anatomy. At the end, you do RGP to identify whether the complete clearance is done and complications. Now, and ultimately, DJ stent insertion is done. All these things can we do without CM at all. That is what, so routinely in URSL, we don't use fluoro for lower ureteric stone. Most of the times we go to the upper ureter with rigid scope without fluoro. Majority of the times it is possible over the guide wire. Passing guide wire into the pelvis can be done without fluoro, because unless the guide wire kinks and comes back, or you are not confident of passing, anybody can understand. Once guide wire is loaded with 6 by 7.5 ureteroscope, that means that the ureter which you have passed is reasonably adequate. This is the first understanding any urologist will easily able to understand. Then coming to the access sheath insertion, when we were doing initially with fiber optic scope, all the access sheath Cook were 9.5 by 11. Not many companies used to make 10 years back except Cook and Boston Scientific in India. Not even local access sheets were available. The normal length we used to use is 28 centimeter. It comes in three sizes: 28, 35, 45. 45 rarely is required. 28 and 35 are required for the Indian population. We always feel that 28 easily goes to the lower ureter and mid ureter. That is sufficient. There is no need to insert high. So needle scope, which is Wolf, by this time everybody might be using. This is the smallest rigid ureteroscope which is available, which is very user friendly, especially when the laser introduced very much into the practice, because in difficult ureters it can negotiate better. Then we thought we passed this Wolf ureteroscope into the 28 centimeter 9.5 by 11. It snugly fits. Snugly fits means there will not be even space for the water, not permeable, not permissible. So if at all they have to go together, like in any visual obturator system, like in TURP. Previously, before doing TURP, we used to put directly by bending the penis. Now we are using the cystoscope through the visual obturator, then outer sheath over that and going into the bladder for TURP. Same thing we have tried, and it helps a lot in not using the CM. So this fact made us to do insertion, avoid CM usage. Even if it goes into the lower ureter, it is okay. Flexi, after that, once you take out, you can identify whether you are in the ureter or not because you are going visually. Second thing, you can come back and see whether you have damaged the ureter that time only. If you have any doubt, come back, visually inspect, stop the procedure. Whether it is by the access sheath or by the ureteroscope, or is it tearing of the mucosa because of the tightness. All the three can be observed before starting the procedure. Once you go into the kidney, what happens most of the times we do plain CT scan. That's why you know one stone is there or two stones are there. You clearly know where you are. So once you go into the pelvis, rarely you require RGP. Why should you do RGP? Normally it is not recommended even because contrast will cause the less efficiency of the laser. So you go and inspect all the calyces. If you have seen one pelvic stone, that is sufficient. You start lasing. At the end, if you make dust completely without making the fragments, you can come out. And how to put the DJ stent without CM, I wanted to share. This is my primary concept of the innovation. Now coming to the stent insertion, normally many of the Indian urologists use 5 French stent, but we are using 3.5 French since long time. 3.5 French stent is very small. It comes in 26 centimeters and 16 centimeters. Even in laparoscopy, ureteric reimplantations, URSL, any surgery related to ureter, we are using this only. The major advantage is that it goes easily into the ureter without any problem. It won't, for example, if you are inserting the stent through nephroscope, through cystoscope, it may kink at the ureteric orifice, it may not kink, it may kink at the mid ureter. Then you have to take the ureteric catheter, then guide wire, then pusher, everything are required along with the CM. But if you insert through the 6 by 7.5 Wolf ureteroscope, this 3.5 French stent goes like guide wire. So if you can go with ureteroscope into the upper ureter, just push it, it will go into pelvis because already you have done the surgery. You know that the flexible scope has gone in. So with that, 3 points. Number one is needle scope ureteroscope, which is commonly used now, which snugly fits into the access sheath. Number two is rigid ureteroscope 6 by 8.5, which is the commonest ureteroscope used nowadays, where 3.5 French stent goes easily. The only thing is which one pushes the stent. The guide wire 0.018 or 0.025 terumo goes into that acts as pusher. The flexible tip can never perforate, maximum is that it cannot go because it will not have strength. It buckles, it curves back like guide wire. So the stent is very small, the guide wire is very thin, it just simply pushes only to go into the lumen, cannot perforate. With this concept, I will show the video. The limitations are, before showing the video, only wolf needle scope can go into 28 centimeters. So your fixed settings make it less. But for us, practical purposes, whenever we are using fiber optic scope, we always use this method for last 10 years, unless there is some stricture. Only if you have put stent already, take it for granted. In all cases, you can do it, because once the stent has gone means you need not look into the ureter for this small sheath. Only 6 by 7.5 wolf admits 3.5 French. Same Olympus, same Starge will not pass this 3.5 French. If you try to pass, it will stuck in between. It is a problem. So the largest channel is the same size scope. Wolf has largest channel because it is little round, not oval. Any upper ureteric stone or stricture obstructing the guide wire, you have to do RGP. You can't say that I will just go blindly with ureteroscope. Sometimes ureteroscope may not be able to go there. Multiple stones in the kidney, if you want to be sure whether you have done or not, you better to do a single shot RGP. So generally 90% of the cases, we don't use the CM. Even CM may not be switched on. Now, the other advantages is, for example, if you have a high bladder neck, you are doing on a more than 60 years old male patient, you cannot pass the access sheath, it buckles. What will you do then? Then you cannot proceed. It's like puncture without access sheath or without the flexible scope not going. If in fact, if you pass the flexible scope in a high bladder neck, it causes immediate dots. That causes severe flexion at the tip. So in that case, you thread over this, go inside the bladder. Even it helps in draining of the bladder. Any urological procedure, a bladder should be empty, so you can drain the bladder also. So these are the advantages of visual operator method. Now you see here, this is a normal ureteroscope 6 by 7.5, and this is the needle scope where it snugly fits. First guide wire goes, then ureteroscope goes, and then see now I am passing, the guide wire goes. You are very clear. Now your scope is going. Along with it, your access sheath goes. Now you have already gone into the kidney. Majority of the times with small scope, you can go into the upper calyx also. Now with this, once you have done this, see now this is a guide wire, and the retros, see that snugly fits. So there is no need for CM at all, unless you want to use a larger sheath. Even for larger sheath, I am telling you, 6 by 7.5 snugly fits. This is 4 by 6.5. Now you have gone inside. You are going on the two guide wires, very safe. One guide wire need not be completely passed. Now you have passed the access sheath automatically. Sometimes you need not push. It just goes with the scope. And you can come back and see, now the flexible scope is going. When flexible scope is going, you know that you can see whether the kink is there, whether I can pass it or not. If you cannot pass in 5 to 10% of the cases, then you think what is the problem. Now you see a small baby here. When you wanted to use under vision in the urethra, because in small babies, penile urethra is very, very dangerous. So there also, are you able to see that? Is it?
No, we cannot see the video, sir. We can see half of the video and half of the.
Yeah, I don't know how it comes. I will just do that. Yeah. Now it is IVP. It's a horseshoe kidney, large volume kidney, or approximate large volume stone. 2 cents. It is a small penis. In this, you wanted to use the access sheath with the even that's the way it goes everywhere. Then you are going inside the ureter, and then is a small baby ureter. You see how I am pressing like any other person presses the ureteroscope. It is already in there. Now this is the access sheath. Now you pass the flexible scope and then do the procedure. Now coming to the this is the water, how it comes. Coming to the DJ stent insertion, you see this double J stent, 3.5 Frenches. Endovasio only makes this, and most of the stones comes by the side of the stent. This is the way how it is threaded. Even with guide wire in situ, see the curve is same. It cannot straighten it. And you pass into the ureter, then only it becomes straight. Now this is the last video I am finishing. And now it goes easily in 6 by 7.5 wolf ureteroscope. The guide wire acts as the pusher. Now I am going into the ureter. Same ureter which you have traveled before. Same urethra you have traveled. Now you go into the kidney. The buckling, too much, sometimes we use See, I'm here. Now this is the ureteric orifice post RIRS. So there will be some amount of, so you can carefully identify. Now the lumen comes. The only thing in this video is not there is you go as high as possible so that the stent has to go into the kidney. It cannot go anywhere. Now in the lower ureter only I am keeping, just passing like that. You pass till the guide wire is seen. Definitely it has to be in the kidney. If it is kinking, you see now it's over. Now you abut the stent to the bladder wall and pull out the guide wire. Now the stent. There is no need to confirm with anything. Just come out. Like this, there is no need to confirm. This is only put only to confirm. So
thank you, Dr. Chandra. We are a little short of time.
This is the buckling of the sheath in the urethra. See, this is the way it buckles in the bulbomembranous urethra, can cause damage. In that case, you can use the ureteroscope and access sheath and come out. This is the eye bladder neck, where you see very high bladder neck like this. In the old people, when you plan for RIRS, you cannot do that. In this eye neck, you can use the access sheath. So with this, I conclude my talk. Thank you very much for giving the opportunity. I am closing the screen.
Yes. Thank you. So a good idea for a minimal usage of your fluoroscopy. And any questions of Dr. Malik? What are your views?
No, I think it's a good idea not to use much of fluoroscopy. There is no denial on that, number one. Number two, his idea of passing a sheet over the ureteroscope, I have my little reservations on that, because there can be a mucosal damage unless it is very fixed. The smaller the stent, the possibility of extrusion is a little high, which is, as mentioned by Aditya also on the chat box. I think that's the only thing, nothing more. It's a personal thing. But overall idea of decreasing the fluoro time, of course, everybody is looking at it and try to. Even PCNL is being done without a fluoro nowadays in China, and majority of the people are adopting to it. We'll go to the, that's what Aditya, I think.
Thank you, thank you. So our next speaker is Dr. Kalun Low. He's talking of using an angiocath in free hand biopsies. Dr. Kulo?
Can I please request all the speakers to restrict to time?
Okay, thank you. So good afternoon from Hong Kong. I'm Dr. Low. Nice to meet all of you. And this is my great honor today to talk about the topic of 14-gauge angiocath, which can be a safe, cheap, and disposable puncture guide in freehand transperineal prostate biopsy. As you all know, that traditionally, urologists use transrectal prostate biopsy to confirm the diagnosis of the prostate cancer. And every year, more than 1 million of trust biopsy has been performed in US and also Europe. However, as all you know, that the problem is the post-trust biopsy sepsis, because we need to puncture through the rectal mucosa before we can get the prostate biopsy. So every year in UK, they spend a lot of money to treat the patient with the post-trust biopsy sepsis. As you all know, that the transperineal prostate biopsy, T-plus biopsy, is totally different as compared with the trust biopsy in terms of the puncture route. At the same time, we can have a very good swabbing over the perineum with disinfecting solution, so to minimize the post-T-plus biopsy sepsis. At the same time, the T-plus biopsy did not penetrate through the rectal mucosa, so that many studies already shown that there have been nearly 0% of the sepsis after the T-plus biopsy. However, as all we know that the T-plus biopsy itself, we need to use a relatively expensive grip, template, or even precision point. However, this is very expensive. One of the precision point is more than 350 pounds per case. As we know that in our center is cannot afford this cost of the instruments. At the same time, in each section, we have at least 8 patients require prostate biopsies. So now we have started our cases with 14-gauge angiocath, which is only cost £1 in each case, so that as compared with the trust biopsy, it did not associate with increased cost as compared with the trust biopsy. So here's our video. I want to show how we proceed our T-plus biopsy. First step is we started with swapping the transpharyngeal region so that we have insert the sci-fi ultrasound probe. First step is to subcutaneous injection of the 5 gram 1% nucleocane using the 23 gauge needle as shown. After that, we can have started our insertion.
Dr. Low, your voice is breaking. You can switch off your video. The transmission will be good. Your this thing video. Your pick basically.
Okay.
The personal video. If you close the personal video, transmission will be better.
Okay. So we just pause.
Not the presentation video. I meant to say your video, which is being in Zoom. Your face.
Okay.
We'll do it from here. We'll do it from here. Yeah. Please go ahead with your presentation. Yeah.
Okay. Yes. So after the procedure, then the patient should be discharged at the same day. So in the first 100 cases that we can share is that there's 0% of the sepsis after the T-plus biopsy, as compared with our history of trust biopsy, where 4% of the sepsis. At the same time, for the C prostate detection rate, we can't find any significant difference between these two methods. So concerning the cost effectiveness of the T-plus biopsy, I think it is very important that we have very important to decrease the cost of the T-plus biopsy. As you all know that the 40 gauge angiogram injection costs £1. However, the cost of the grip, template, or even precision point is very expensive. At the same time, because we do the T-plus biopsy, we save the cost of the sepsis. So totally, we can save a lot. Especially in Hong Kong, the hospitalization daily cost is around £300 every day. If the patient requires intensive care due to the sepsis, the daily cost is even higher than £3,000 every day. And also the patient after sepsis require a 1 week course of antibiotic, which is intravenous route. So if the hospitalization for 1 week, so the cost will be very high. And also because every day we do a lot of prostate biopsy. So if we can change 1 million of the trust biopsy to T-plus biopsy using 40 gauge, so that the total cost of puncture guide cost can be minimized. At the same time, we can also save the cost of sepsis due to trust biopsy. So to conclude my presentation, by saying that the T-plus biopsy using the 14 gauge angiogram can avoid penetrating the rectal mucosa and the blood exposure to the bowel flora. This accounts for the zero sepsis complication rate at the same time without increasing the minor complication as compared with the trust biopsy. At the same time, the prostate cancer detection rate, the T-plus biopsy has not shown is not inferior as compared with trust biopsy. And also, if you use a 40 gauge angiogram, it can also save the cost as compared with other brand of the very expensive one. So this is the end of my presentation. Thank you very much.
Thank you, Dr. Kalun. Your video, we were just able to see the very beginning of that. Can you just actually play the procedure? We just saw the prepping happening and your probe going in, and then it got switched off.
Okay, sure. We can just play the video. This is our video.
We can't see the video.
Oh,
can you go to that particular slide and then play the video? I think you're playing from outside the class.
Sure, sure. So let's see if you can see the video or not. This is the video.
No, not yet.
Yet.
You'll have to go back to the presentation, the PPT, and go to that slide and then play again. Because you're sharing the PPT right now. Yeah.
Okay, sure.
It's not happening. Can we? Can we?
Somebody,
Request, I
can
think
somebody do it at your end?
No, sir. For that, we'll have to take control.
Okay, that's unfortunate.
Is it happening? Is it working, Doctor? We can't see here.
Yeah, I try to open up again.
Yeah, just try once. Otherwise, you can share it on the page later and for us to see.
Sure, no problem. So let's see if you can see now.
Yeah, please go to that particular slide and then play the video. Yeah, it's running.
Okay, it's now going. Very good.
Yeah.
So this is the video that we would like to show to all of you. This is the first step.
Can you mute the sound of that particular video? Just mute the sound of that video. I think we should be able to hear you better.
Okay, sure.
Yeah, please now.
Is better, right?
Some issue. Okay, forward.
This is yes, this is the video. So we start with the insertion of the sci-fi ultrasound probe, and then we have insert our loop anesthesia. We have inject subcutaneous injection of the 1% thing.
Dr. Kalu, it's not running. The video is not running.
So can we
be a problem?
So I think later, sir. Can we request him to share it on the page later?
Yeah, I think so. I think so. It's not working.
We'll go to the next Aditya.
So I am
Sure. Maybe we can share.
Dr. Kalun, please you can ask.
Okay, sure. We will just we share later.
Yes. So let's. Thank you for your nice presentation. Can we get the next speaker? Arvind, you are going to show us a new needle holder.
Yes.
Welcome, Arvind.
Thank you very much, Urology Group. I also thank the chairpersons to grace the chair for this particular talk. I'm going to talk about this novel prototype 3x5 laparoscopic needle holder. We went through the past 10 to 15 presentations, and this is how we saw that the innovations were developed. But just to put it on exactly to put everything in perspective, advertently or inadvertently, we are following this particular guidelines. That is, they are called as the ideal guidelines, and they are developed from the Delphi consensus process, which ideally say that any innovation has to pass through these 4 steps. It may be a surgical procedure or an instrument. That is innovation, development, evaluation, analysis, and long-term follow-up. So basically, in the first 3 steps, we have got the proof of the concept, followed by we develop that particular innovation, learn over it, and then do the assessment. So as far as my innovation goes, the idea developed like this. Any surgical procedure, either open or laparoscopic, comprises of 2 major processes, that is cutting and suturing. And suturing is the most challenging part. And out of that, laparoscopic needle holder is the key instrument to achieve this particular step. The factors which help us in proper suturing are as follows. First is the shaft size. The shaft size of the laparoscopic needle holder, if it is the same as that of the port, then the physiological tremors will be less. If the tip is narrow than the shaft, then you will be able to see the knot, and the knot will be seamless. So there should be a correlation between the diameter and the circumference of the port. Smaller the size of the port, greater will be the stability. So the unmet need is that the needle holders, although available in number of shaft sizes, the commonest one available is a 5 mm shaft size needle holder. The shaft size and port diameter discrepancies are there, which leads to wobbling of the needle holder. That is, commonest combination is a 10 mm port with a 5 mm shaft. So the third thing that we have to remember, that all laparoscopic needle holders should work like a type 1 lever. That is, equal part inside the abdomen, equal part outside the abdomen. This is particularly accentuated in pediatric patients. So what we need to achieve is that we should have a needle holder with a 5 mm shaft, with a that goes through a 5 mm port, and which has got a very narrow tip at its end. So the reason to have this, I must acknowledge Professor Mallikarjun for this. I saw this particular principle called as gesture imprecision in one of his presentations. As you can see that the discrepancy, now you see it is a 10 mm port, and you can see that the shaft of the needle holder is 5 mm. So that eventually leads to a lot of wobbling, particularly when a novice is doing it. So this is how the idea developed, that we developed an needle holder with a 5 mm shaft. And in order to make the knot more seamless, we thought that so the thoughts were, if you see the last line, we thought that how about having a needle holder which is having a 5 mm at the shaft and 3 mm at the tip. Then I think we'll be able to fulfill all these requirements. So this is how we conceptualized and developed the needle holder. The top one is the conventional needle holder with a 5 mm shaft, but the prototype that we are describing is a 3x5 needle holder. That is, the shaft is 5 mm, but the tip is 3 millimeters. And the most important thing is that you see that at the junction of 3 millimeters with the 5 meters, there are no screws. So whenever you throw any knot in a conventional needle holder, actually the screws will make the knots to entangle into the screws. So basically, these are the USPs of this particular one. I was talking about the instruments being in type 1 lever. So generally the shafts are 31 centimeters. We need to have a needle holder which is shorter in size. So that makes this a type 1 lever, which again helps in better suturing. This was the working line diagram. As you can see, I want you to just have your attention at this point that everything is welded. We don't have any screws anywhere, which helps us in avoiding screws and knotting of the throws that we are making. Just to show a needle holder in action, you can see the way the shaft comes through the shaft, which is 5 millimeter. There is almost no wobbling. And going a little bit further, you can see that apart from proper grasping of the needle, it also helps us in throwing the knot, and the knot does not get entangled in the screws. Anything has to be validated. As I said, that E out of ideal is the evaluation or analysis. So we also tried to evaluate this particular needle holder with a conventional needle holder, with the prototype needle holder, in 2 groups, expert and novice, with 2 tasks. Task 1, grasping the needle, and task 2, suturing. And the two needle holders were conventional and the prototype needle holder. And of course, the laparoscopic endotrainers were used for the purpose. And we elicited the following 4 questions in a Likert scale: 4 items for handling of the needle holder and 4 items for suturing. So as you can see that all possible questions were raised: ease of handling, ease of gripping, ease of unlocking, etc., etc. And what we found is that definitely, if you compare the novice group, definitely the time for task 1 was less in the prototype needle holder. Definitely the time was less in the prototype needle holder, even in the expert group. That was same for task 2 as well as task 2 in novice. So if you can see, the needle holder has fulfilled the phase, construct, as well as all the validities that are required for fulfilling an validation study. You can see that among the ease of handling, there was an ease of visualization of knot, particularly at the tip while throwing multiple knots. There was more ease in gripping the needle holder, particularly when using the prototype needle holder. There was ease in unlocking the needle holder when that particular action was completed. And finally, the item 8 was also in favor of the prototype needle holder. The long-term follow-up, that is the L of the ideal, we thought that we will try to bring it out through this particular study, which was published in JMAS, and it was a validation study comparing it with a conventional laparoscopic needle holder. I must say that Ashish Patil would agree with me that anything that you innovate should be protected from as far as the intellectual property goes. We also that I must say this is just at the patent filing application stage. How to popularize it? We also collaborated with a few market players by the name Shriji Surgicals. Any new you have to have someone to just give wings to your thought. And we thought that this particular needle holder should be marketed through this one, and we thought that we should have it. This needle holder should be tribute to our guru, Dr. Mahesh Desai. So it was named as Desai Gantule Bhagat 3x5 hybrid needle holder. So the bottom line is that we feel that the expert laparoscopic surgeons as well as the novice laparoscopic surgeons performed laparoscopic suturing faster and with more ease while using the prototype 3x5 laparoscopic needle holders. These last 2 sentences I think would be more relevant for this particular group and this particular session, that there should be a cohesive partnership between the industry and the innovator to yield results, because it's not just enough to have your ideas just in one closed room. It has to be propagated. But currently, we feel that the challenges for innovations in India include that we as clinicians or users, we prefer products with big brand names. I think this particular mentality should go away. must admit that there are a few regulatory and administrative bottlenecks. And I feel that in India, at least in India, the innovation should be incentivized so that more and more people embark on this particular journey. Thank you very much.
Very nice, Arvind. I think we have been using it we have been using it quite some time now. It's a good innovation. And as I said, that gesture imprecision, if you get it down, in any laparoscopic suturing, your performance will go up significantly. We cross over that basic principle and come on to trying to do the best thing with manipulating the instruments and your technique rather than the physics or physiological principles of suturing at that point of time. Very nice, good, and it's worthwhile. Even I still use it. I don't know where I bought it, but we still use it for, especially for a small needles like pyeloplasty needles.
Thank you very much, sir.
Aditya.
Yeah, I think I have used your needle once as a demonstration. This Sri fellow had brought it along. I also found it quite useful. So any questions for the panel? Right, so let's go to the next presentation. Thank you, Arvind.
Thank you. I'll just stop sharing.
Yes, please.
You can go to the next speaker.
So Dr. Kaushik is speaking on Super Perk. The next speaker is on Super Perk, Dr. Kaushik Shah.
Yes.
Is he there? Yes, Dr. Kaushik.
Yes.
Yes, good morning, Dr. Kaushik.
Can I share my screen?
Can you share your
slide?
Go
Go ahead.
Hello.
Yeah, you are audible. Go ahead.
Please share a PowerPoint presentation, sir. We can see the desktop.
Are you able to see now?
Yes, sir.
Yes.
Yeah. Good morning to everybody. I thank the organizer for organizing these wonderful things. And thanks to all of you for inviting me to share my work. Today, my topic is how to incorporate the SuperBook in your current practice. Wait.
You are the most.
We were getting the presentation earlier, sir.
Yeah, but it was a different version. So.
Okay. Should we move on to the next presenter and come back to you, sir? No,
yeah, you can do that.
Okay.
Okay, it's all right. I got it.
Okay, you got it. Okay.
Okay. So I'm going to speak about this, and I thank Dr. Mahesh Bhai for continuously encouraging me for the work I have done. So whenever we are innovating anything, it is important that it reaches to the audience, and any innovation is useful when the people are willing to use it. They put money, time, and energy to use that innovation, then only it has a meaning. When we are doing any of this PCNL, we are doing a lot of jugaad because we are facing a lot of problems like this. And when we face these problems, I decided to innovate, and it is possible to reduce all these problems. PCNL is a unique upgradation on PCNL, slender PCNL, mini POC, micro POC, ultra mini PCNL. So you can say that it is a PCNL with a suction and retrograde irrigation irrespective of the size of the tract. So the basic design of this is that there is a sheet, there is a connector, and there is a dilator. Now when we are using this thing, the second part is suction with a tap here. When there is a tap, it is very easy to empty the bottle, and there is a stone catcher bottle which we can use, and therefore it is very easy to collect the stone fragments. This is a multi-hole ureteric catheter. So this is another thing, that it is an open-ended ureteric catheter along with multiple holes, so that the fluid goes from multiple openings. So in superbox system, there are three changes. One is at the insertion of the ureteric catheter, use the multi-hole ureteric catheter under CM guidance and put it in an apocalypse. Second change is that instead of using a conventional renal sheath, you put any of these sheaths, 12 French, 15 French, 18 French, 21 French, or 24 French. And when you are using, use a suction for fragment removal. So this is a whole system. First change is in the multi-hole ureteric catheter. Second is a superbox sheath. Here it's an air opening. If you close, the suction is activated. If it is open, part suction is transmitted. Here you use a suction tube attached. So when you are starting the procedure, you keep the system ready. So when you want to start, you just attach a tube here. Rest of the things are already prepared when we are draping the situations. And you can use any nephroscope. You can use any lithotripsy device. So when we are doing the PCNL, first step is the puncture, and then there is an initial dilatation. Many people skip this process and go directly to 12 French or 15 French and put a respective sheath. But if we want to go for higher, it is important that we do an initial dilatation and then put a guide rod. After that, it is a one-shot dilatation to 18, 21, or 24 French sheath. So it is practically a one-shot dilatation. So when we are doing a PCNL, the stone size can be 5 to 15, 15, 25, or more than 25. And the common procedures which we do for a 5 to 15 is UMP or mini-POC SX or a mini-POC. If you use UMP, you have this telescope, then you can use 12 French sheath, and you can use a laser and complete the procedure. So just by changing the sheath, you can add the superbox in your armamentarium. If you are doing mini-POC with a 12 French nephroscope, or even URS can be used as a nephroscope, and there you use 15 French or 18 French sheath, and better is a pneumatic, so that fragments can be better, bigger, and it can be taken out and the procedure can be faster. If the stone is slightly bigger, many of us are using mini-POC, then you can use 12 French nephroscope, or those who are not having this, you can use URS. 15, 18, and 21 French sheath can be used depending upon the size of the stone, and pneumatic is the first choice, laser is the second choice. If you have a slender nephroscope, then you can use the 17 French nephroscope and use 21 or a 24 French sheath, and you again use the pneumatic so that the procedures can be easily cleared. And when we are using a bigger nephroscope, stone, we can use mini-POC, but the sheath size, if it is 18 or 21, much bigger fragments can come by the side of the nephroscope, and minimal withdrawal of the nephroscope is required for removal of the stone, and you can use pneumatic. And if you have a slender nephroscope, you can use 17 or 18 French nephroscope, and you can use 21 or 24 French sheath. And if you have a standard PCNL like MIPL or a Dresden nephroscope, then you can use a 24 French sheath. So in short, whatever the technique of PCNL you are using, whatever the sheath size you are using, you can use the same sheath size. Plus, if just by changing the sheath pattern, you can incorporate this system in your practice. I am running a short video so that you can understand how it is. There are a number of videos available on the website, superpoc.com. So after putting a guide dilator, you can use this sheath. Now the distal end is such that it is very easy to hold, very easy to manipulate, and by slight rotatory movement, you can advance without a jerk. And when you confirm that it has reached, the fluid will start coming from here. That shows that you almost reached the system. And you can take out the dilator, leaving the guide wire in situ. Now, when you kept the tube ready, you just attach here, and all the fluid that is coming from the system will go into the bottle. And here is a stone catcher bottle, and then this tube will go to the suction machine. It will go to the suction machine. This is a low power suction machine. And there is a tap, bottle with a tap. Now, you do the nephroscopy with a standard mini POC, because this is a 15th range. And if you use this, it is like any standard POC. It is like an M+ sheet. Now, when you are removing the fragments, you put a finger here and it will immediately activate the suction, and multiple fragments can come out from the sheet, and you can manipulate, you can see, and the moment the fragment comes closer to the sheet, it immediately finds a way into the sheet, and you can withdraw. In this way, you can inspect the whole system, take out all the fragments, and the procedures can be much simpler. You don't have to pick up the fragments, and the system is always collapsed. There is no increased pressure here, and the bottle can be emptied continuously. Here there is a bottle, and you can see.
Dr. Kaushik, sorry to interrupt. Yes. We are running out of time. Can you hurry up,
okay. So when we want to start using a sheet, you can use just like this sheet. This is one way to start using a sheet, and continue doing the way you are doing. Second, if you attach the tube, again, it is possible to collect the fluid and fragments in a standard way. If you are using only connector, not connecting, then the in and out movement of the scope becomes much easy, because you don't have to take out the nephroscope completely. When you want to distend the system, you close both the ends, and so that the fluid will not come out, and you can distend the system. That is very important when you are trying to find out the calyx which is collapsed and the stone is inside, or when we are doing a supine PCNL and the system is getting emptied. So there are a number of situations where we want to distend the system. It is possible to do this way, and if you do this, it is a suction activated, and whenever you want to use, you can do. So by just changing the sheet, you have a number of advantages without disturbing what you are doing. So the special features of the sheet is that all the benefits of M+ sheets are still available even if you use it. The suction is on demand. It is outside the irrigation channel. It can be controlled by the surgeon or assistant. It's independent of the lithotripsy devices. It can never get blocked. The sheet is extremely lightweight and durable. You have a control on the renal pelvic volume as well as the pressure. It is very useful in hydronephrotic system, and very useful when we want to remove the stone in a bulk. The advantages are of the you have a complete and simultaneous of PC system when you use a multi-hole ureteric catheter while puncturing. The fields are clear. You don't need a forceps. Fragmentation time is also reduced because you fragment not dust. Dusting approach is not required, and it reduces the migration rate. If you see the stone going away, you just activate the suction and it will come back towards you, and therefore it improves the surgeon's comfort and reduces the nephroscopy time. It gives better clearance, and multi-hole ureteric catheter is an excellent exit strategy because it drains extremely well. Thank you. And if someone wants, yes,
wonderful,
you can visit. Yeah.
Wonderful, thank you. I think it's a proven fact that addition of a suction into this area will improve your. It will not spoil your field all the through and get the fragments out much faster. One of the biggest challenges is fragment extraction in APCNL. It's a great idea which has been sold well, and I think it's many people in India are already practicing this. I expect probably in the next 6 months you devising something more beyond this, which has been seen past 2-3 years now, something more happening in your field, and again, some modifications which will be much more of benefit. Thank you, Kaushik.
Yeah, there are 2 projects which we are going to come out, and it might be take 6 months or 1 year,
Good,
and you will see something different. Yeah,
that's exactly.
Yeah.
We'll be. I'm ready.
I'm happy that these seats are used across the world now.
I know that. I know.
Yeah,
I said that you and Kaushik, Ashish have become MNCs already.
No, not MNC, not an MNC. We are
Okay, Rahul, excuse me. Okay.
Yeah, just a passing comment and interrupting in between. Malik sir has to leave for another meeting. Sir, I must say your comments and views are lucid and scholarly as always. And it's an auditory feast to listen to you, sir.
No,
Sincere thanks on behalf of Team Alto, sir, for
Thank
accepting the chair for such a difficult session, in fact.
No, it's my pleasure. I learned something today. Thank you very much, Rahul. I'm sorry to disconnect now itself. Thank you very much.
Thank you, sir.
Aditya, to go ahead with yours. Thank you.
Yes, please. Yes. Thank you, Dr. Malik. So our next speaker is Dr. Ashish Chajed. Thanks. Our next speaker is Ashish Chajed. He's talking on the iLab trainer. Ashish, are you there? Ashish?
Yes, sir. Just okay.
Yeah. Hi.
My screen is visible, sir.
You are audible and visible. Go ahead.
I would like to thank Ultoid and everybody involved in bringing this innovative idea of bringing innovations in mainstream. I would like to thank Malik sir, Pradhan sir, and everybody. And I would like to present this idea which I had started. And this idea is lot of credit goes to the lockdown to finalize and conceptualize and finalizing this idea. So the background of this started with this, that simulator is an excellent tool for initial learning curve and standardizes our steps in laparoscopic suturing. But the commonly available simulators cost around 12 to 15,000 without instruments and 18 to 20,000. That's what idea we have got. And it's a bit cumbersome, not much, but you need a fixed settings, you need a OT setup or at least a OPD-like setup and locked workspace. And the vision, the cameras, optics, most of them, these are actually VGA cameras and not up to the mark. So the idea arrived when I was watching these photographs from my phone and streamed it to my television. So just as I was thinking whether I could incorporate this idea and use it in laparoscopic training and make a simulator out of it, which will help largely in laparoscopic simulators. So what I needed a smartphone, which everybody has a very good smartphone, either an iPhone or good quality. Most of the phones, modern day phones now have a 4K recording, HD recording. So vision, there is nowadays no limit. You can get excellent visualization. Then you need a streaming device, which can be either Apple TV or Amazon Stick or a Chrome Sticks. And I think most of these things are available at everybody's home. This streaming is now coming up in a big way in India. Then you can use any available light source, which is a LED light, a laparoscopy box. Meanwhile, I made a simple box, which I had a medium-sized box, and some hand instruments. So these are the instruments. This on the left side is the LED source, which I use for magnification loops. Then this is the Apple TV source. There's some hand instruments which I already had. And this is how I'll just play a short video of 2 minutes, which will clear out all the ideas. So this streaming device nowadays are available everywhere. This is the small latch, and it was very helpful in adjusting the view of the smartphone and view of the streaming. So we will discuss the advantages later on. This is how it started. Box trainer. What we have done is we have made a cutout here and box, and we have attached that mobile holder here. This is our LED source. We have punched a few holes in the box so that we can pass these hand instruments inside this, like this, like this. So after that, it's very easy. We have to connect your phone to the streaming device. This phone is connected with the TV already, with that Apple TV and streaming device. So with my mobile, I'm just connecting this on. And once I keep it on and place the mobile in the slot, once you do that, you just have to your camera on, twist the phone and keep it like this. So we have already kept it here. So as you can see slight amount of this vision on this camera. So this hole is completely covering. So there is no total. It is just looking like a laptop simulator. Whatever we are doing here now will be automatically streamed. Now if you can see the colors and everything perfectly ready now. The advantage of this system is that, see, if you are struggling with the vision and if you want to zoom it in, you have to just do this. You have to just zoom it from here. This is a very simple application, but it can be very widely implemented by a lot of people, and most of the things are available at home. This is what the purpose of video and the purpose of the innovation.
Dr. Ashish, can you mute the sound of that video so that we can hear you clearly?
So that you can do everything from your home. Like, this is a very simple streaming. This is a streaming device is showing everything. There are a lot of advantages. So it is a no cost. Like, everybody is having these streaming devices, mobile phones, everything is at home. What we need is just a simple box and few modifications. And zoom in, zoom out is a very important function which we can do. And lot of the times while using a simulator, we have to put the box up, adjust the screen, then put it again. So this is very easily solved with this system. Then 4K and HD camera is there. Excellent colors are there. The colors which you will get will be as good as your smartphone. And it is again a wire-free and hassle-free. So the entire TV unit is on one side, and your console, so the laparoscopy unit and the box is on one side. Very easily possible with this. So what are the scope which we are developing? We are in a process of designing a better box and a shell which will be standard. We want to make it so easy that you have to just get a box, put the phone on it, and you don't need any other thing for laparoscopy. Other thing is we will simplify the connections and illuminations and make it totally wire-free and plug-and-play model. We are also in a process of designing a mobile app so that whatever lines you get while doing these laparoscopic suturing and while the dots, that will also be completely screened, which will be eventually be making it. And we want to make it so easy to assemble that every surgeon in training uses it with minimum things which are needed for this, just like a box or something. I think that's it. It was a very simple innovation, and we have a lot of things we will be taking it forward. But the idea behind it was to make it available at everyone's place, at every training, at every hospital. Where simple training can make it a laparoscopic training.
Very nice idea, Ashish. Thank you very much. That was wonderful. I think now every resident coming into every department has perforce got to buy one streaming device before he joins the department. Wonderful idea. Thank you. So we have now our last speaker, Dr. Abhijit. He's also going to talk on a simulator, a portable mobile-based simulator for beginners. Dr. Abhijit Patil, please.
Yeah. Hello.
Abhijit
Good morning,
Patil.
sir. Yes, sir.
Hi, Abhijit. Welcome.
Hello,
Please.
sir. I bring greetings from Nadiad. Good morning, everybody. On this occasion, I would like to take an opportunity to thank the organizing group ULTO for coming out with this good idea of showing all the innovations, and this may stimulate all other urologists to come up with all simple cost innovations. So the innovations being done in developing countries is that they are very cost effective and they can be used in large scale population. So I am bringing out this a new portable warm-up laparoscopic surgical simulator. It is a mobile-based application, but it is probably a bit different from what Dr. Ashish sir showed. So as Dr. Ganpure sir said, that any innovation has to go through the steps of. So coming on to it, the idea or the problem. So first, the problem is that the Hallstedian model of C1 has represented the primary method of teaching since ages. So the advent of minimal access surgery has indeed benefited the mankind, but it comes with the price of steep learning curve. So to in acquiring the skills, we rely on surgical simulators, cadavers, animal models. But cadavers, animal models are difficult to get the permissions. They are costly. So we are left with only surgical simulator as an option. And it is sometimes difficult and risky for faculty to teach the trainee directly on patients. And nowadays, as and by the number of seats and number of residents are increasing in a hospital, and since the hospitals are also increasing, there is there is a discrepancy between the training a surgical trainee would have in this current era. So, as I said, the cadaveric animal model based are difficult to get permissions and are costly. Uh, in surgical simulators which are available commercially are very costly and thereby restricting surgical simulation to many trainees. So the genesis of this idea is that I had completed my urology training in a government hospital. So when I came from there to Nadiad, Nadiad has a very good wet and dry lab facility. So there are lots of simulators, commercial simulators available at Nadiad. So when I learning on that simulators, I thought that the benefit which I am getting, all my other colleagues are derived of it. So I thought of creating a simple solution to it. And thus this is a surgical simulator is a low cost solution and would be probably a boon to all the surgical residents out there. So the surgical, I'll basically describe it. So these are the ingredients of it or the components of it. What did I do is we generally get this mobile stand. This is basically a prototype and we are in a process of tying up with a commercial company so that they can make it in a well form. So this prototype what I made was using two mobile stands attached a wooden sheet to it so that it gives weight to it, doesn't wobble, and to further add to prevent wobbling are those 4 easily available suction cups which are attached to this. So when you fix it to the base, this will not move. And then initially we had in our mind is that we have a acrylic sheets and they were actually straight, rectangular. But then as we thought that there are many box model available out there, but the limitation is various port positions which can be tried. So we came out with this idea of having a curved thing and multiple holes in it so that we can have multiple port position, multiple settings in a single endotrainer. And these are made up from all simple things which are available. The weight, it is lightweight, it is just 500 gram. We used a mobile for this, or even an iPad can be used on this. So the benefits of a mobile is that it can be used as a screen, it can be used as a light source as can be seen here, it can be used as a camera from this. So camera, screen and light source, all things in one thing. Then as I said, this is a nut, so you can slightly loosen it up. You can extend, make it up and down, make it medial laterally. So you can have different port position. You have 2 different holes. You can use instrument here. You can use instrument here. So you have various different port position. And also, since this is a mobile based, the mobile can incline or decline wherever you want. Then we did some task on this mobile skin simulator and they look pretty well as can be seen in this picture. So, and the other thing which we tried from this is that this would be very beneficial for video calling and doing a training. Suppose, for example, we are doing training from here to some very remote of place where a surgeon wants to learn laparoscopy. We can train him from here. So I'll show you how it works. So this is the basically simple ingredients which are required to make this. If you want to make it, then this is a 360 view of how this prototype endotrainer looks like. So the surgeon is sitting down there and he cannot see actually what is happening on this side. So this is how a 360 view of this prototype looks like. We are in a process of making it in a better way so that it can be manufactured on large scale, and we will try to keep the cost of the endotrainer to limited so that many of the surgical residents would be able to buy it. And as can be seen, it pretty does a good job. These are some exercises which we asked some of our residents to do it. Stacking up the sugar cubes. And as can be seen, we are not, the surgeon is not able to see whatever is happening on that side, and he is trying to stack it up. And then this comes the idea of distant learning. So a person over here would have this endo trainer. Since this was a single prototype, the other surgeon at a distant place would also have this. Since you can see, this is how the teacher is sitting here and the student is sitting here, and the teacher has already passed the suture through the tissue, while the trainee is still struggling to hold a needle and pass it to the tissue. So this is how the teacher can show it from here via video call to the trainee. You have to hold the needle this way. You have to pierce it this way. So this can be used especially for distant learning as well. So this is our commercial endo trainer which we have. It is around 2 kgs except the weight of the TV, and it is somewhere around $150. And here this is around 500 gram, and it hardly costs the $10. So, and you can see, so this was the crux of the solution, is that any surgical trainer should be able to carry his surgical simulator anywhere with him, especially in his bag. So he puts the simulator in his bag and takes it wherever he wants, especially during his hospital hours before any surgery. So the benefits of this project are, there are various mobile based or tablet based home made simulators out there, but the limitation is portability, fixed port position, and camera angle. So this simulator, as I showed, it gives benefit of various port position. It can be inclined to various angle. It is lightweight and portable. Every surgical resident can have one for personal use, since it would be a very low cost, and everyone in this era probably has a smartphone. So the other use is that a surgical resident can record its own simulation log. And so when he comes in the first year, he can record how efficiently he can do suturing, and at the end of 3 years, he can the teacher can assess whether he has improved his learning curve over the time. It can be used as a warm-up. Suppose I want to do pyeloplasty, lap pyeloplasty today. So I will take this simulator in the OT. I will try suturing just before I do surgery, and then I would vouch for doing a laparoscopic pyeloplasty. So this can be put in the bag. Where we can use it in the OT room, surgeon's room. We can practice there and then go to the OR and do the lap pyeloplasty. The simulator can be used by both by the resident mentor differently, and then they can be especially useful in rural areas or economically deprived areas. So this will boost surgical training of resident whom minimal access. So comparing it is these are the various components of the device, and it hardly costs 750 rupees. That is around 9.9. That is $10 today. While all the commercially available trainers are very costly, you require to buy them, you need to maintain them, and it is a huge cost, especially for a developing country. This was the idea, that was the development, and as was said, we tried to evaluate it with the commercial endo and tried to prove its validity. Any innovation without validity is probably one's own thought. So to scientifically validate it, we tried exercises. We involved experienced surgeons, and we involved residents with surgeons. So these were some of the exercises. There was the description, and then we asked them to rate on experience, difficulty, usefulness, and to make it objective, we assess the time required to do that exercise. Whether a part of the exercise, if there is a penalty, then that penalty would be added. So this is how we made it objective. Then we asked every novice and expert to rate it. So majority of the novice rated it more than this was out of 5. So as you can see, it is quite rated well. Face validity, also experts thought that it is quite good in all of these questions that we asked. So it proved the content validity. They said the maneuverability is good, high-end coordination is good, the exercises are representative to learn laparoscopy skill. Even they thought that this should be a part of the surgical residency, and they would change the ease of doing the laparoscopy surgery. The simulator is portable, it can be used as warm-up, it can be used for recording, and also for distant coaching. Then we assessed the scores between the commercial endotrainer and this new endotrainer. All the parameters are not significant, proving that this endotrainer is at least not inferior than the commercial available endotrainer. And it definitely differentiate between an expert, as experts had a low scores and novices had a high score. So that means that it can differentiate between the expert and novice, and that proves its construct validity. What I want to point out is what are the population benefit, what are the target population to benefit. So there are lots of urologic resident
Abhijit, sorry to interrupt, can you summarize now?
Yes, sir. So basically, it will be used for all residents, especially every resident can have it. Also, in rural population, this rural government or hospitals lack facilities. So the lack of confidence to perform minimal access surgery on patient deprive them of the benefits of the minimal access surgery. The simulator can be performed anywhere without any high-end gadgets, without any electricity, just a simple smartphone and this device. So this will probably translate in not only urological resident learning it, many general surgical as well as gynecological residents learn. This is how I want to conclude that it is a low-cost, homemade, lightweight, portable trainer, can be used by trainees at home as well as office, can be used as warm-up exercise, can be used for recording and evaluating their own skills, and it can help in distant coaching. And at this outset, I would like to thank Nadia for this wonderful brand wet lab, and my father who actually helped me out in making this device. Thank you.
This is a fantastic idea, Abhijit. You have completely got rid of a box. You've completely got rid of the monitor, no transmitter, and literally the person carries it in his laptop bag and goes home. It is a superb idea, and you have actually validated it so that you added strength of evidence on what you have been doing. I must congratulate you for this wonderful device.
Yes, sir. Thank you.
And there have been plenty of comments coming your way on the chat box, and I'm sure you can see it on your Facebook post after this. Thank you very much.
Thanks a lot, sir. Thanks a lot.
Thank you,
Thank you, sir.